Good afternoon, everybody. By way of introduction, I met some of you yesterday. My name is Dr. Broderick. I practiced emergency medicine for nearly 3.5 decades. So most of the talk and the discussion that we're going to do today about musculoskeletal trauma comes from real life scenarios. I think one of the best ways to learn is to give you case presentations, and then we'll dissect what the issues are, what the problems are, and how you would address that as a frontline clinical person. As I mentioned, there'll be a follow-up lecture to this where there's a little bit more hands-on involvement, but today we'll focus on our case presentations. Sound reasonable? And by the way, thank you for having me here today. It's a pleasure to see all these young, wonderful faces. Okay, so case number one, most of these are going to have, can you see that okay? Most of these will have a radiograph, plain radiograph with them, and then a narrative. So I'll go ahead and read this while you're looking at that x-ray. So you are the sole provider in a rural ED when a 24-year-old woman presents with right knee pain after an injury while playing soccer. On examination, the patient has 1+ dorsalis pedis, posterior tibial 1+, that's in her right leg, the affected leg, and her left leg, her left foot, 2+ pedal pulses. Right knee has obvious deformity with a limited range of motion. There are no open wound or skin changes. Obviously, when you have open injuries over an orthopedic injury, there's another level of concern that you have as far as secondary infection, etc. So this is a closed injury. So what stands out to you immediately with this picture, with this x-ray?
Floating. Displacement.
A floating patella. So here's your patella up top there. Doesn't project real well. Just by way of anatomy, what bone is this?
Tibia.
Femur, patella, tib fib. Should it look like this? No, it should not look like this. Should not look like this. So you think this is a fracture or a dislocation? Dislocation. So dislocation, a knee dislocation. Does it take a lot of force for this or not so much? This is a tremendous amount of force that it takes for a knee dislocation like this. Tremendous amount of force. The anatomy in this area, you obviously have major vascular structures that run through the popliteal fossa, and you have neurologic structures that run the popliteal fossa. So both of those are under a tremendous amount of stress and strain, and potentially tearing with this injury. So you saw that in the narrative there. The patient has decreased dorsalis pedis and posterior tibial pulses. We grade our pulses 0, +1, or +2. Ideally, when you examine a patient's extremities, you always want to compare to the unaffected side. So if a patient has +2 pulses on one side, you would expect them to have +2 pulses on the other side. So diminished pulsation on this. It doesn't comment about neurologic status in this particular one, but you would also, as you're evaluating this patient, you would want to assess for sensation, you would want to assess for ability to move the foot properly, wiggle the toes, just a very crude neurologic exam to make sure that there's not significant neurologic damage. So this is something that needs to be addressed sooner rather than later. So the question would be, should you attempt extremity reduction right away? Should you just immobilize it and wait for the cavalry to arrive? Would you send the patient for a CT angiogram to assess the degree of vascular injury? Or would you transfer the patient to a higher level of care? What might you want to do right away? What's your name? Polina. What might you do right away? A CTA of the right knee? Is that a C? Or was that a, I love this lecture.
No, it's
Okay.
It's both.
Okay, so the CTA of the right knee, what's that gonna tell us?
It's actually going on.
It's gonna tell us what the vascular integrity of that area is, right? Is there good arterial perfusion and circulation? But you already know clinically that there's compromise. A CTA of the leg is gonna take a little while. You send them over there, you send them over to the CAT scanner. You gotta inject dye. Usually before you inject the dye, you wanna assess for kidney function to make sure you're not gonna make things worse. So while this patient may require a CTA, it likely wouldn't be the first thing that you would wanna do. So you really wanna restore normal anatomy. So this is a scenario where you really wanna try and realign and reduce this dislocation. So you really want to attempt extremity reduction. And when you have dislocated major joints, you are always concerned, specifically, let's say a posterior hip dislocation. Vascular compromise is going to lead to an aseptic necrosis of the femoral head in 1 year from then, and they're going to have long-term problems. So as best you can, you should try and reduce reductions as quickly as possible, specifically if they have neurologic or vascular compromise. So this patient already declared vascular compromise with a diminished pulse. You can see from the schematic here that the distal femur lies posterior to the tibia and the fibula. They should be much more in line, and we may have a picture of normal lateral anatomy. The nerve that is commonly injured is the common peroneal nerve, and the artery is the popliteal artery. So the goal for that is early reduction. Okay, here's another case. This looks a little bit different, right? So this is a AP view. You're looking at that knee from front on. So you look at that knee. A 16-year-old girl, and usually this injury occurs in younger people. A 16-year-old girl presents with knee pain. The patient was dancing when she suddenly developed pain in the right knee and was unable to walk. Physical examination reveals the above image. What management is indicated? A, admit for operative repair. B, close reduction. C, CAT scan of the knee. Or D, joint aspiration. What might you want to do with this patient? They don't really talk about, too much about vascular compromise or neurologic compromise, but I'll tell you that normal vascular, normal neurologic examination here. What is the nature of this injury? Pardon me? So scan of the knee, CT scan of the knee, correct? We'll get to a little bit of what do you think the nature of this problem is? What does this appear to you? What is this deviation? This is the patella, a dislocated patella. This is one of the most enjoyable injuries as an ED doc or a first-line practitioner because they are so easy to reduce. The patient comes in with their knee flexed or on the stretcher, they're writhing in pain, they're very uncomfortable, usually they're very exaggerated, and in about 5 seconds you can reduce this and the patient instantly feels better. You reduce this through extension, and so this is lateral extension, and just with 2 hands, just with your thumbs, pushing the patella medially. And it goes right back, so easy like this, so easy. And the patient feels so good. I do these in the ER without even getting an x-ray, because the exam is so typical. To wait for an x-ray, the person, usually by the time they come in my ambulance, it's 15, 30 minutes, 45 minutes since the original injury. They're very uncomfortable, they got a lot of pain, they're usually, just very, very uncomfortable. So to be able to walk into the bedside, quickly assess this. If you're comfortable with what your diagnosis is, you can reduce this without even an x-ray. This is one of those ones where you really, if you've been doing this for a while, you don't need the x-ray to understand. Because what's the worst that could happen? Let's say she had a patella fracture. You still need to reduce this. You're going to reduce it regardless of whether there's a patella fracture or not. What's causing this to happen? The patella slips out of its groove and gets stuck laterally. The patient's knee is flexed and it's causing a lot of tension. So by extending the knee, you allow the patella to be pushed back medially, and the patient feels immediately better. So again, we'll do this next week on that. Go ahead. This is my feeling on giving procedural sedation for that. If it takes me about 3 to 5 seconds to do the reduction and they instantly feel better, no. I mean, you could, but now you're talking, you need an IV, you need all this stuff. You don't know if they're going to have a reaction to the medication. When was the last time they ate? If you give them too much medication. So this is one of those ones that I don't even muck around with procedural sedation. There are other ones we'll talk about as we get through this. There's some where, yeah, it's a little more humane to use procedural sedation. But for this one, because the pain is instantly relieved and they feel so much better, and then they can actually leave a half hour later, with just a knee immobilizer on. You don't have to have them hang around for a couple of hours. So this is the most common type of lateral dislocation. The examination shows the patella displaced laterally. Diagnosis is made by clinical exam and an x-ray to rule out fracture. Again, if you've been doing this for a while and you can kind of assess, most of the time you don't even need an x-ray. The treatment is reduction and knee immobilizer, and then they can follow up. And this is more common in females, and it's more common in younger versus older. If you've had repeated patellar dislocations, you're probably going to need some definitive procedure done. Some type of operative procedure where they will actually, it's not a matter of shortening the patellar ligaments to prevent this from happening. They try and build up some of the bone to prevent this from slipping out of this area. And good physical therapy.
You mentioned that the patient came in on an ambulance. So, pain-wise, is it really high pain for this condition? And would you recommend give them medication?
So if I got the radio call and the ambulance said, we got a young lady, describes this case, she's in a lot of pain, I'd say, where are you? They said, we're backing into the ambulance bay. I'd say, just get her inside. We'll take care of her right away. This is one that I'll sometimes do on the gurney, on the ambulance gurney, before you even move them onto the stretcher, because they instantly feel better. If they tell me we're 25 minutes out, it's going to be a while, definitely I would give her something for the pain. Okay, we'll switch to a pediatric case here. An 18-month-old boy presents to the ED after he fell off his bed and hurt his leg. Does anybody have young children? They're generally pretty active, little 18-month-old boys. It's not unusual they might fall off the bed. The child is otherwise healthy and he's up to date. UTD is up to date on his vaccinations. Physical exam is notable for an uncomfortable appearing child who will not speak with the physician and will not walk secondary to pain. Remember, when you see a child, your examination of that child starts the second you walk into the room. Actually, while you're still outside the room, you're watching how they're interacting with people in the room. You're kind of assessing, because this kid fell off the bed, did he hit his head? Are there other injuries? Everybody's focusing on his leg, but you want to make sure there's not other injuries as well. He's refusing to walk on the leg. His vital signs are normal. He's given some oral analgesics and his leg is immobilized. Which of the following is the next best step in the management of this patient? CAT scan of the femur. You try not to give lots of radiation to particularly pediatric cases. Radiology will usually give a weight-based imaging, so they will turn down the dial for little children so they don't get as much radiation. So CT scan of the femur, DEXA scan, that's probably some type of nuclear medicine scan, I'm not sure what that is. Operative treatment, or skeletal survey. So I'm not sure. I don't know why this isn't, you probably can't see that real well. So femur, patella. This is an unfused growth plate here, doesn't have two patellas. This is the abnormal area here. Okay, this is the abnormal area here. So what might you want to do with this kid? Is this somebody you want to scan? You want to get a nuclear medicine scan? You want to call your orthopedic surgeon for treatment, or do you do a skeletal survey? And why would you do a skeletal survey? If you did a skeletal survey, why would you do one?
He fell off the bed, so you want to check for other.
You want to check for other injuries. Is there anything about this particular injury that concerns you? He fell off a bed. Is anybody here falling off a bed? Yeah, I don't know if the mechanism equals the injury. So what should you be thinking? You guys are all mandatory reporters. What should you be concerned about? Child abuse. Anytime you have a story that does not necessarily match up with the physical examination or the radiographic findings, you have to consider child abuse. As a first-line provider, physician provider, you have a responsibility to make sure that no harm was done to that child. So you have to at least consider it. Failure to consider it could lead to worse injuries down the road. A skeletal survey is something that we do to see if there are other orthopedic injuries varying in time. Does this child have multiple heel rib fractures? Does this child have another fracture that you see signs of healing on? So that's why we order a skeletal survey. A couple of the classic injuries that we see in child abuse, obviously certain type of burns, the demarcation of certain type of burns, certain type of injuries that don't go well with the story, retinal hemorrhage from shaken baby, subdural hematomas from shaken baby. This particular type of fracture, this metaphyseal corner fracture that you see in that previous one, that's not what you typically see if a child falls off of a bed. You know, maybe you'll see a little wrist injury or something. It takes a lot of force for that. This is a type of a twisting or a forceful type of injury. This type of fracture is suggestive of child abuse. It's actually called a bucket handle fracture. It's at the end of the growth plate at each end of the long bone. Other classic orthopedic injuries, posterior rib fractures, takes a lot of force for posterior rib fractures. Fractures at different periods of time, bruising, various parts of the body. Some children have Mongolian spots on the back. I don't know if you've ever seen a child with that. And if you're unfamiliar, it may look like bruises running down the low part of the back. Don't be confused. Those are typically, that's normal. That's normal melanoma in the skin. One of the classic ones for kids is a torn frenulum from a hit to the face, causing the lip to tear upward. Obviously burns, very classic type of burns, belt marks, etc. When you see a kid with an injury that doesn't make sense, make sure that you disrobe that child completely. You disrobe that child completely, you put them into an examination gown, and you check them from head to toe. If you don't look, you're going to miss things. So these are the ones, we have a rule in our emergency department, regardless of the nature of the injury, for every child under the age of 5, they had to be completely disrobed and with a gown on. Make sure you, if it's a little child with a diaper, even though it's a knee, open the diaper. Look at the backside. Look for other areas of injury. Because again, I've had cases over the years where patients have come to the emergency department 2 or 3 times over a 12 or an 18-month period of time. And then ultimately they come in with a very serious injury. And when you look back in time at those prior visits, there was something that was a red flag. That if you had your antenna up, you might have caught that and prevented that. The other thing, when you're considering child abuse, you don't need to be 100% certain. By reporting a case, and all physicians, nurses, healthcare providers are mandatory reporters. If you believe that there could be an injury and you do your assessment and you're still not 100% convinced that this is a benign injury, you have a duty to report. And then it's up to a process to determine whether that really was child abuse. You can't know for sure. You have an encounter in an emergency department or an office visit, but Child Protective Services have databases on, because let's say this kid went to 3 other ERs over the last 6 months, and they had a file on this kid that showed that there were repetitive situations. It's going to add up a little bit differently versus somebody that had one isolated injury. So just bear that in mind down the road. Whether you end up, whatever setting you end up, you're probably going to have some exposure to children during your training, and always have that, in your mind, is this potentially child abuse? Okay, case number 4. A 36-year-old man presents to the emergency department with ankle pain. He states that he was jumping to grab a ball and he was playing basketball and he felt a pop at the back of his ankle. On exam, he has a positive Thompson test. What is the appropriate next step in the management? Apply a splint with the ankle and slight plantar flexion. Consult orthopedics for surgical evaluation. Obtain CT angiography, rule out vascular. Place the patient in a controlled ankle movement booth. Does anybody know what the Thompson test is? Anybody know what the Thompson test is? You'll become familiar with this. Basically, the patient lays prone on the stretcher. They flex their knee to 90 degrees, and you compress the calf. By compressing the calf, you're applying tension to the Achilles tendon, and the foot should plantar flex. So by squeezing the calf, the foot's going to plantar flex. If you do the Thompson test and it's positive, that means the foot did not flex. So what injury does this patient likely have? Ruptured Achilles tendon, right? Positive Thompson test, felt a pop, and has pain. Doesn't say that he can weight bear, but would not be able to easily weight bear and push off. What kind of people usually get the Achilles tendon ruptures?
Heavier guys? Bigger, heavier guys?
Bigger, heavier guys, certainly there's a lot more stress and strain. People that maybe had a lot of repetitive use when they were younger with sports. Do you remember the medication that now is a black box warning for Achilles rupture?
Macrolides?
No.
Fluoroquinolones.
Fluoroquinolones, exactly. Cipro. It's a big black box warning in the PDR. So this would be somebody that you want to put in a splint with slight plantar flexion. We'll show you a little schematic here. You would not put them in a controlled movement book. That might be for just a little ankle sprain. So you can see by the schematic here, the swelling, the Achilles tendon rupture versus a normal, well-demarcated Achilles tendon. Typical little things, stop and go, twisting, basketball, soccer, previous Achilles tendonitis, Males are more common, overweight, older age, kind of the weekend warrior, we say, somebody who, works at a desk job all week and then, weekends is out there playing, I don't know, recreational softball or, soccer on the weekends or something. And then obviously a history of recent fluoroquinolone use, steroids as well. There's another injury that you can get in your calf. So here's the scenario. I'm walking along, I go to step up on a curb, and I felt like somebody hit me in the back of the calf with a baseball bat. It jolts me, I look back, and I don't see anything foreign on there, but it really hurts when I try and walk on that. What type of injury is that? Plantaris longus rupture. This is very common. People come in thinking they ruptured their Achilles tendon, but it's usually proximal third of the calf. It's a small vestigial muscle and tendon that is prone to rupture. Usually with just a little time and rest, it heals. The only problems would be is if maybe you had somebody who was on an anticoagulation and had some bleeding. So usually is, again, Achilles tendon in summary, patient's usually a decommissioned athlete, maybe a history of quinolones, feel a pop or a snap in the lower calf area, absent plantar flexion, that's the positive Thompson test, posterior splint, plantar flexion, and they're going to need definitive repair. But it doesn't need to be done right away. Usually they let the swelling go down a little bit, be done in the next, I don't know, seven days or something like this. This isn't something that the orthopedist needs to admit the patient to the hospital and fix. We talked about plantaris longus rupture. I guarantee you, sometime in the next, I don't know, couple of years, you're going to come into contact with somebody that had an injury, and you're going to be able to diagnose it just by the history. Yeah, I felt like somebody hit me in the back of the calf, and now I got a little bruise there. That's a plantaris longus rupture. And again, anybody on anticoagulation, antiplatelet therapy, much more prone to bleeding complications. So these are the ones that you want ice and elevate, try and make sure that they're not having any complications of bleeding. Okay. We're doing time, okay. A 22-year-old man presents to the emergency department with foot pain after landing on his foot improperly while playing basketball last night. Using this image, what is the diagnosis with this patient? Chopard fracture, Jones fracture, Lisfranc fracture, or a pseudo-Jones fracture. And I'll point out the fracture if you haven't seen it yet. So by the way, this is a foot x-ray, not an ankle x-ray. The ankle looks all messed up there, right? But that's just because of the angle of the way. They want the ankle bones, the tip fib out of the way so that you can really see all of the foot structures and the tarsal structures. Here is your fracture, right here. This is your 5th metatarsal fracture here. Usually happens when somebody jumps and they come down on the outside of their foot, or they land on something uneven and come down on the outside of the foot. This is what's called a Jones fracture. What's the problem with a Jones fracture here? What are we worried about with these? Pardon? Avulsion fractures usually are like a little piece of the bone comes out due to the ligaments. It's almost like you took a piece of grass and you grabbed it and you uproot it from the soil. That's what an avulsion fracture is. Because of the location, the blood supply to bones like this come from the two ends, like this. So when you have fractures like this, you worry about malunion due to vascular compromise and poor healing. So there are 3 types of fractures of that metatarsal bone there. You can see that here at the bottom here, you can see this is your avulsion fracture. This is pretty common. You see this a lot. Usually it just heals with a soft boot, a wrap, and maybe some limited weight bearing. Those heal fine. This Jones fracture are the ones that you have to take a lot more seriously and follow those to make sure that there's normal healing. And then obviously for people that are marathon runners or people that run a lot or maybe do a lot of weightlifting with heavy pressure, you can get stress fractures. These are difficult, the stress fractures are difficult to diagnose because you may not see them on a regular X-ray. Those are the ones maybe where you get a bone scan or you need to get an MRI to be able to detect a stress fracture. Again, these you don't really worry too much about, the pseudo-Jones. The Jones fractures are the ones where you have an increased risk for malunion. Those other ones that we talked about, this is common in professional athletes. You may see a Lisfranc or a Chopard fracture. These take a lot of force. These are the ones where you have a professional football player or a professional soccer player that has a foot injury, and then they're out for a year because these things take a long, long time to heal. The Lisfranc fracture, that's this joint here. A lot of disruption of ligamentous structures in the foot. The Chopard fracture, more proximal into the tarsal bones. These take a long time to heal. And oftentimes these can be a career-ending injury for professional athletes. And the x-rays on these, you're not necessarily going to see a, quote, fracture, because this is mostly dislocated joints, but it's very subtle. Because of the structure of the foot and all of the ligamentous and tendon, you may dislocate this, but it kind of goes back to the way the normal anatomy might look until you stress that joint, and then you can see that you've disrupted those ligamentous structures. So this is sometimes difficult to diagnose. So one of the things that in a lot of orthopedic type cases, if you do an x-ray and you don't particularly see a fracture or dislocation, sometimes we'll do a stress image where you'll put that joint under a little bit of stress. Example might be a shoulder subluxation or a dislocated or a subluxed AC joint. We'll actually have the patient hold a 10-pound weight in each arm, and you'll see the asymmetry of one joint opening up and the other one staying intact. So sometimes you need to stress these joints to really be able to pick it out. Or of course, more advanced imaging, MRI or CT scan would probably be able to pick that up. Let's see, we talked about this. So the pseudo-Jones, that's that avulsion fracture. That one, you just need a bulky dressing, put them in a shoe, tell them weight bearing is tolerated. The Jones fracture, you're going to need a hard cast, at risk for malunion, non-union, non-weight bearing, close follow-up with those. Okay. We'll go to the upper extremity for a little bit here. 20-year-old patient presents with a traumatic shoulder pain with a noted deformity. An x-ray is shown, which is the following is the most likely diagnosis. Acromioclavicular joint separation, that's your AC joint right here. Anterior shoulder dislocation, inferior shoulder dislocation, or posterior shoulder dislocation. First of all, what's the most common shoulder dislocation? They give you three types here, B, C, and D. What's the most common one? Anterior is the most common. Anterior, the ones where patient comes in, they fell on their shoulder, they come in and they're holding their arm like this. Because the head of the humerus is now displaced anteriorly. They come in like this, it's very obvious. Any movement, they're having lots and lots of pain. Inferior is the one where they come in with their hand over their head like this. And the humeral head is subluxed inferiorly to the glenohumeral joint. They come in like this. I had a lady one time that was doing yoga. And she was in, I don't know the position, but she had her arms straight. Maybe she was shaped like a V like that, or a downward dog, or cat, something like that. And she dislocated her shoulder. She came into the trauma bay with her arms stuck up like this. She could not get it down. That's the second most common injury. And then the posterior, maybe about 5% of the cases. Posteriors are difficult to diagnose because sometimes the x-rays difficult to read. The risk factors for a posterior dislocation, a lot of force. Somebody who has a seizure may cause a posterior dislocation. Somebody with electrocution can cause a posterior dislocation. A lot of anterior force, a direct blow, can cause a posterior dislocation. So this one, if you look at the x-ray, and again, the spread doesn't show up real well. I don't know, this doesn't look that bad. It seems like it's maybe in the right place. See, you're not sure. This is what's called the Y view. The Y view. You see the scapula here? The humeral head is supposed to be sitting right at the base of this Y, right there. So you know something's not right with that. You know something's not right. So we'll say something's not right. We're going to figure out what that is with another set of x-rays. Okay, so this is what a normal shoulder should look like. If you look top left there, you can see your humeral head. It actually is supposed to overlie and overlap with the glenoid fossa. So you should see the humeral head kind of sitting in there. The glenohumeral joint is not like the hip socket where it's, all in socket. It wanted to be, but it never really became one. So it's really supported by your rotator cuff and your other muscular structures holding that shoulder in place. So humeral head normally will overlap with the glenoid fossa. You can see the greater tuberosity here. You'll sometimes see with anterior dislocation a little fracture in the top of that glenoid, that greater tuberosity. It's called Hill-Sachs deformity, and it's usually due to compression of that when the shoulder is dislocated. So this is normal up here. And as I mentioned before, that humeral head should be sitting in the center of that Y, which is the lateral view of that scapula, or actually it's a Y view they call it. So if you can see that humeral head sitting in the Y. So now we look at this particular case. This one, the humeral head is not overlapping with the glenoid fossa. There's diminished overlap. And when you look at the Y view, it should be sitting right here. It's all the way out here. This is what's called the light bulb sign, because when that humeral head dislocates posteriorly, it also twists. So you see the humeral head twisted, it's called the light bulb sign, versus if you look at this particular one up there, you see the normal anatomy. This one, you can tell that it's rotated in a funny way. Maybe there'll be another view of that. And it takes a lot of force for this. Either a direct blow to the anterior or an axial loading, violent muscle contractions from either a seizure or electrocution. This might be the one where you have somebody come in that's working on a power line and they have a terrible electrocution, they come in with shoulder injury. I've seen patients with an electrocution that have bilateral posterior dislocations. So when you hear electrocution or a lightning strike or prolonged protracted seizure with shoulder pain, think, without necessarily falling injured, think posterior dislocation. Anterior shoulder dislocations are pretty easy to detect on clinical exam. You feel there's just a pause, there's a gap, there's a hole there because the humeral head is just sitting down and you can just feel you look at them and you look and it's like, that's not right. It's not symmetrical, you lose the normal contour of the shoulder. Posterior ones, it's a little bit different. They don't look that abnormal. They don't look, but they're in a lot of pain. And you see that x-ray there. Like we said, you can sometimes have associated fractures. If you have somebody that has a shoulder dislocation, they have a tuberosity fracture, you still got to reduce it. So we'll call the orthopedic sometimes say, yeah, they had shoulder dislocation, have a fracture. But let's say just reduce it, get it back, send them to the shoulder immobilized, and they will put some definitive thing. Because they probably have other disruptions there that are going to need some type of repair. So this is typically going to be able to be reduced in the emergency department and then with close follow-up. When we do some of the hands-on orthopedic work. We'll show you how some of the techniques, and there's an interesting technique that you can do also, if you're alone, let's say you're skiing or you're out in the wilderness and you have a fall, how you can reduce your own shoulder if you're fairly certain that you have a shoulder dislocation. Because normally it's maybe a 1 or a 2 person reduction, but you can actually do it to yourself. So an AC joint separation, that's the acromioclavicular joint. This is a separated shoulder is what they cause it. We grade them typically 1 through 5. 1, 2, and 3 usually just heal without too much. 4 and 5 means usually it's a complete destruction of the AC joint, and you're going to need maybe some surgical repair. These are the people you see. I had a grade 3, and I still got a bump here. These are the people that you see if their shirt is off. You see one of their acromions, just kind of clavicle head sticking up, and there's a space there. It's very, if you've seen this injury, it's very obvious when you see somebody. So it doesn't cause even if it heals, it causes cosmetic deformity. One of the problems with shoulder injuries, once you've caused a disruption in the normal anatomy, you're much more prone to have subsequent arthritis, rotator cuff injuries, long head of the bicep tear, once you've had prior disruption of the normal anatomy of the shoulder. So the anterior we talked about, that's the most common one. As we said, this patient had a posterior dislocation. Inferior, again, luxatio erecta, that's the one where they come in like this. So with those, what you basically do is you take this and you convert it to an anterior dislocation by reducing it, and then you reduce the anterior dislocation like you might normally do. So it's a 2-step process for an inferior dislocation. Again, we talked about history of seizure, electrical injury, a physical exam. Usually you don't get much vascular compromise. You might get a little bit neurologic, so it's always good to check sensation across the deltoid to make sure that you haven't impacted axillary nerve, any other neurologic structures in this process. The inferior dislocations are much more prone to neurologic injury than posterior or anterior. Okay, we got time for a couple more cases. 34-year-old woman presents with elbow pain and diminished arm movement following a fall on her outstretched hand. You know what we call that fall on outstretched hand? Foosh, F-O-O-S-H, common injury. Somebody falls like this. When you have force by falling on your hand, the force is going to get radiated up the arm, right? So you're either going to have a wrist injury, elbow injury, or shoulder injury. Because all that kinetic energy of landing there has to be dissipated somewhere. Has to be dissipated. So it's either going to be a wrist, elbow, or shoulder injury with a fall to the outstretched hand. So pain, swelling, and tenderness over the elbow, inability to fully extend the elbow. Which of the following is indicative of a radial head fracture? Should we give you a wrist drop? No. You get that with a distal humerus fracture, radial nerve. Posterior fat pad sign, we'll get to an x-ray, we'll show you what the fat pads are there. Nor a posterior fat pad. So fat on an x-ray turns out what color? It's black. Fat on an x-ray is black. Just like air on a chest x-ray is very black. So fat is black on an x-ray. This radial capitellar line, that's really more of a supracondylar fracture. So we're going to say that, let's see what this lady has here. Posterior fat pad, abnormal and more specific for fracture. I misspoke. You can see an anterior, it's kind of hard to see with the lights on in here, but you can see that this area is a little blacker. You can see definitely this is blacker than the surrounding tissue. So that's fat that normally you would not see on a lateral x-ray. It's called a posterior fat pad sign. That usually means there's some type of intra-articular swelling or an effusion causing that. When you look at this this x-ray, so you got humerus here, you look, nothing real obvious with that. Radius, ulna. The only real abnormality that you see in here and in here is where you typically have radial head fractures, but often you can't see it on a regular x-ray. So if you have somebody that has limited range of motion in their elbow, they've fallen on an outstretched hand, and they have this posterior fat pad, that's a fracture till proven otherwise. And you're gonna wanna immobilize that in some type of comfort, either sling or comfort immobilization. Because the most important thing about this, depending on which one obviously you have type 1, 2, and 3. Most of these, the biggest problem is loss of range of motion. So these are the ones where you want, if it's a 1, maybe a type 2, you want early range of motion exercises so you don't lose any range of motion. Again, fall on an outstretched hand, localized swelling over the radial head, posterior fat pad sign, sling, outpatient follow-up, ortho referral. They generally don't require surgery. Child with this, children don't usually get this. This is the supracondylar fracture that children get, and that's a bad fracture. And they can cause a lot of problems with that. So if they have a fat pad sign in a child, you've got to really consider that supracondylar fracture. Before we do this case, I'll give you just a 2-year-old child comes in refusing to move his arm, his or her arm. They come in like this. You ask the parent what happened. They say, I don't know, we were walking, he was holding my hand, and I went to lift him up over the curb, and then he started crying. What do they call that? You tap your clavicle? Could be. We call that a nursemaid's elbow. Nursemaid's elbow typically comes in, and the radial head slips out of the little ring that it's in. And they got this because back in the day, when somebody was walking, the babysitter or the nursemaid was walking with the little child, the curbs were maybe 12 inches. The kid was a little kid, and they had to lift them up to get them up over the curb. And in doing that, they would dislocate this radial head. Not a big deal. It's kind of like that patellar dislocation, very easy to fix. And then they're fine, they don't need any aftercare. I had a neighbor, Linda remembers this gal. Her kid kept having a dislocated radial head. And I kept trying she'd bring the kid over and I'd fix it at the house and tell her, don't do that anymore. She called me one time and said, it happened again to Freddie. I'm like, what did you do? She said, well, I went to lift him up and he fell down and now he won't use his arm. I said, well, you've seen me do it 2 times in the past. Can you do this yourself? And so I explained to her what to do. She called me a half hour later and said, it's not working. I said, all right, I'll be home. Just bring Freddie over to the house. We'll fix it up. Came over, I put it back in and went back in place. And I said, show me what you were doing. She goes, I was doing exactly what you said. I was turning his arm and I was touching his shoulder. I said, what I told her to do was turn his arm and then have him touch his own shoulder. But she was just turning his arm and then she was touching his shoulder. So I've learned that you got to be very specific when you're trying to give instructions over the phone. Needless to say, that didn't work. Okay, 75-year-old woman with osteoporosis fell on her outstretched hand. Her x-ray is seen below. Again, this is Fouche. It's either going to be a wrist, it's going to be an elbow, it's going to be a shoulder. What's the most likely diagnosis here? Distal radius fracture. You can see it. Comminuted distal radius fracture. Fracture has a specific name. What do we call it? Colles fracture. Very common and with osteoporosis, fall on an outstretched hand. Sometimes you'll have a little older styloid fracture along with that. This is a common injury. We would see this, 2 or 3 times a day in the emergency department. So distal radius fracture. Not a big mystery there. It's also called a dinner fork deformity, Colles fracture. You can usually reduce these with finger traps and a little bit of weight here. Sometimes you'll do a hematoma block to make it a little bit more comfortable. But just sometimes, just by leaving the weight on there and the fingers in a trap, you can get these to reduce, and then you maybe just give a little shove and then you immobilize them. They typically don't require surgery, but if they involve, if they're more involved, they may require surgery. Okay, everyone's fallen on their hand there. A 14-year-old girl presents to the ED with wrist pain one day after falling onto an outstretched hand while playing soccer. She has normal sensation of movement, normal radial pulse, exam unremarkable, tenderness at the anatomical snuff box. Does everybody know where the anatomical snuff box is? People that used to do snuff, I don't really know what snuff is, but they put it here and they like this, okay? So this is your anatomical snuff box right here. What bone sits under that? Scaphoid or navicular, whichever you want to call it, the same thing. So that's a common injury that you'll see with a fall to the outstretched hand. The difficult with that is oftentimes you won't see it on an x-ray. You won't see it on an x-ray. It can be very subtle. These are the ones where sometimes if they have snuff box tenderness and the history is there, even if the x-ray doesn't show it, you immobilize them in a thumb spica splint. And then you'll re-x-ray that in 1 week. Believe it or not, I broke both of my naviculars. One jumping off a balcony when I was in college, and the other skiing out in Aspen. Not skiing, but I was running for the bus and I fell on the ice. So yeah, I've experienced that both, not at the same time. There's a story about the balcony, and it's a very innocent story. I was late for class trying to get there. So you can see scaphoid fracture. What's the problem with scaphoid fracture? It's similar to the Jones fracture. Non-union. Again, the most common is the middle part of the scaphoid, and the blood supplies come from the two ends, so it's at risk for a non-union. X-ray, CT, bone scan, MRI. I think, do one of our kids have this? Did Jesse have this? You had everything. Yeah, I have a couple of active young men now who are young active boys with a lot of orthopedic. One of them had this, playing tennis, went to jump over the net, tripped over the net, landed on his hand. He ended up having surgery and a pin put in there. So sometimes they require surgery, sometimes they don't. And the most common is through the middle third of the bone, and that's why you're at risk for non-union. Okay, I think this is our last case here. A 42-year-old woman presents to the ED with left wrist pain. She slipped and fell on the ice, falling forward onto her left hand. Her wrist radiograph is shown above. What is the diagnosis? This is a tough one. I've had this, I've also missed this one. So just to get your anatomy, okay, this is a kind of a lateral view, lateral radiograph of the wrist. So Colles fracture, we saw that. Does it look like a Colles fracture? I don't think so. Scapholunate dislocation. This probably wouldn't be the type of view that you'd see that in. So we'll narrow it down to B or C. Lunate is one of the bones in the wrist. So obviously, if it's a lunate dislocation, that bone is dislocated. If it's a perilunate dislocation, that means things dislocated from the lunate. In other words, lunate properly positioned, the other carpal bones dislocated from it. So we'll show you. It's a tough one. And usually it's very painful. The wrist comes in very swollen. You'll see these people and you say, I don't see a fracture, but they're like really tender, can't move their wrist. These are the ones where you need to sometimes get some additional films to take a look at here. So the difference between a lunate and a perilunate, again, it's whoosh, fall on an outstretched hand. Wrist fullness, lateral view shows a spilled teacup. So you can see here, this is the lunate bone. Lunate bone. The lunate should look like this. If it turns like this, that's a lunate dislocation. If the lunate is upright, which you can see here versus here, then it's a dislocation around there. So this is a perilunate dislocation. This is a lunate dislocation. They're both very difficult to pick on X-ray. So these are the ones where the wrist is really swollen, really tender. They can't really move it at all. You get the X-rays, you don't see a fracture. Typically, you can say this is just a sprained wrist. Think of this diagnosis. This is the one often where on Saturday morning after a Friday night with somebody who had this, we get a call from the radiologist on Saturday morning saying, I saw you discharge that guy with a wrist sprain. He had a perilunate dislocation? And then we're like, oh shit, you gotta call him back and reduce that. Because the longer these things are out, the more you have a difficult time. Median nerve injury. These are the ones in the orthopedics. We've actually been able to reduce these in the ED, but sometimes these might be the ones that would require conscious sedation or procedural sedation because it takes a lot of force and it's a very uncomfortable injury. Okay, I think that concludes. So we did 10 cases today from really pretty much upper extremity to lower extremity. A couple of the takeaways. If somebody has neurologic or vascular compromise, don't wait. Do something about it right away. If a patient's in pain and you're fairly certain about a type of diagnosis of dislocation and you feel comfortable reducing it, just go ahead and get it done right away. Fall on an outstretched hand, the force has to go somewhere, wrist, elbow, or shoulder. Remember, somebody who has an electrocution or a seizure and comes in with shoulder pain, you get the x-ray, say, that doesn't look that bad, think posterior dislocation. Then make sure that your radiology technician gets that wide view. Because if you just saw an AP and a lateral view of that shoulder, it might be hard to pick up. The wide view is the diagnostic one on that. All right, any questions? I didn't expect you all to become orthopedists out of this, with maybe the exception of Julian, but I didn't expect all of you to become orthopedists out of this, but just a general way of how you approach musculoskeletal injuries. All right, thank you very much, and we'll see you same time, same place tomorrow.